arthritis and rheumatism. And 7.6 million people are living with disability due to back pain and spinal problem. That means more than 16 million US adult population are suffering from some sorts of disability like arthritis, rheumatism, and also back pain. Now you can see, first we have seen that why patients visit a doctor. These are the 10 most common medical condition with which the patient visit a doctor. And you can see about 34% of the patient visit a doctor due to arthritis or rheumatism, and it is the second most common cause. And 24% of the patient visit a physician due to back problem. That means 58% of the patient visit a doctor due to either arthritis or back pain. So this is a huge burden for our society, also community, and also for our country. Now, come to the overview of the joint pain. Joint pain may be due to interarticular structural problem or periarticular structural problem or referred from the distant side. Pain due to interarticular structure, it may be inflammatory pain or not, that may be mechanical condition. Among the inflammatory condition, it is infectious arthritis. That means it may be viral arthritis, it may be tuberculosis, or it may be septic arthritis, and also rheumatoid arthritis in spondyloarthropathy and crystal deposition arthritis. Among the non-inflammatory condition, most common is osteoarthritis and also internal mechanical derangement. And due to periarticular structure, it may be due to pain due to bursitis, capsulitis, tendinitis, and extraarticular disorder like polymyalgia rheumatica and also fibromyalgia, and some systemic disease like SLE, systemic sclerosis, that may also cause pain, and referred from our distance sites. Now, when a patient comes to a doctor, what should be our goals? Our goal should be accurate diagnosis of the joint pain, whether this is a mechanical condition or inflammatory condition. Where if it is inflammatory condition, whether it is rheumatoid arthritis or spondyloarthritis or any other condition, and timely provision of the therapy. This is very important. Sometimes joint pain may present as a medical emergency like septic arthritis. If we don't treat the patient or if we delay treatment, there will be permanent damage of the joint, and which may lead to disability of the patient. And avoidance of the unnecessary diagnostic testing, which is very important. In most of the cases, diagnosis of the joint pain or rheumatological diagnosis is clinical, but we do investigation to support the diagnosis, not to exclude the disease. Now, what is the overview of approach? When a patient comes to a doctor with a joint pain, our first priority should anatomical localization of the complaint, whether this is the articular pain or non-articular pain. That means it is periarticular or referred from the distant side. And second is determination of the nature of the pathological process, whether this is the inflammatory pain or this is the mechanical pain or non-inflammatory pain, and extent of the involvement, that is whether it is a monoarticular pain or oligoarticular, polyarticular, focal, or widespread, and determination of the chronology of the joint pain, whether that is the acute onset, that is less than 6 weeks, or chronic onset more than 6 weeks, and formulation of a differential diagnosis. From the differential diagnosis, we should reach a definite diagnosis to start treatment as early as possible. Now, I'll discuss how can we differentiate inflammatory and mechanical pain. Inflammatory pain is maximum after rest and decreases with activity, whereas mechanical pain occurs with use and relief by rest. And inflammatory pain has got morning stiffness more than 30 minutes, but mechanical has no morning stiffness or mild morning stiffness, and it may be less than 30 minutes. Inflammatory pain has got redness, swelling, warmth, but mechanical pain has no redness, swelling, or warmth. And in inflammatory pain, one of the characteristic features is the stress pain, that is increased towards the extreme range of movement. This is called stress pain, and the pain is felt throughout the movement. In inflammatory pain, there is fine crepitation, but in mechanical, there is forced crepitation. In inflammatory pain, acute phase reactant, that is ESR CLB, will be high, but in case of mechanical pain, this will be normal. Now, what is this stress pain? Stress pain that increases toward the extreme range of movement. It is two types. One is universal stress pain and another one is selective stress pain. Universal stress pain increases toward the extreme range of movement in all direction. That is, may be both flexion and extension, and it is the surest sign of synovitis. That means universal stress pain is the surest sign of synovitis, and selective stress pain increase pain towards the extreme range of movement in only one direction. Now, non-articular pain may be rapid pain or periarticular pain. Rapid pain is the pain which is felt away from the site of the origin. It is reproduced by stain on the originating, not by the stain on the painful structure. It may be associated with skin hyperesthesia. It is diffuse and ill-defined, and it is improved by measures over the site of the pain, and it is variable in distribution. Now, what is the difference between articular and periarticular pain? Articular pain, if it is held in neutral position, that is loose peg position or fetal position, but on the other hand, it is held in lower tension position. In articular pain, there is capsular swelling, but on the periarticular pain, there is got and it is in periarticular pain, decreased movement in only one direction, that is in the plane of the tendon. And here is joint line tenderness, only localized tenderness is present. Universal stress pain is present in articular pain, but in periarticular pain, selective stress pain is positive, and there is warmth and there is triggering sensation. Now, how can we evaluate? For tools of evaluation, it is proper history taking, examination, and some lab test. During examination, patient must clearly explain their problems, and the physician will clearly identify their problems. So, during examination, what can we do? We have to do physical examination, that is general physical examination, locomotor system examination, examination of the other system. Locomotor system examination, it is inspection at rest and inspection during movement, and palpation movement, the palpation of the joint and also periarticular structure, and palpation also during movement. Now, during history taking and during examination, we have to identify some things, whether the pain is true arthritis or arthalgia. Now, what is the difference between arthalgia and arthritis? Arthalgia means only pain in the joint. There may not be any signs of inflammation, but arthritis means inflammation of the joint. Here, pain, redness, swelling, increase one, stiffness are present. When a patient presents with arthalgia, it may be fibromyalgia, bursitis, tendinitis, hypothyroidism, neuropathic pain, metabolic diseases, the osteomalacia, and depressive illness may also present with arthalgia. Now, we can diagnose the patient according to the site of involvement. When a patient presents with symmetrical arthritis, it may be rheumatoid arthritis, SLE, systemic sclerosis. When a patient presents with asymmetrical arthritis, it may be osteoarthritis or spondyloarthritis. Where there is large joint involvement, it may be osteoarthritis or spondyloarthritis. When patient presents with GIP involvement, it may be nodal osteoarthritis or psoriatic arthritis. When the patient presents with MCP pain or PIP, this may matter of axial or proximal interphalangeal joints. This may be rheumatoid arthritis and also SLE. First metatarsal typical presentation of the gout. While the patient present with spinal pain, it may be osteoarthritis, ankylosing spondylitis, psoriatic arthritis, and reactive arthritis. And fibromyalgia rheumatoid may sometimes present with shoulder pain. Sometimes patient may present with migratory arthritis. If the patient present with migratory
according site of involvement, we can diagnose the patient. When the patient presents with symmetrical arthritis, it may be rheumatoid arthritis, SLE, and systemic sclerosis. When the patient presents with asymmetrical arthritis, it is osteoarthritis and spondyloarthropathy. When the patient presents with large joint involvement, it may be osteoarthritis or spondyloarthropathy. And when the patient presents with DIP involvement, it may be nodal osteoarthritis and psoriatic arthritis. And when patient present with MCP and PIP involvement, it's rheumatoid arthritis and SLE. And first NTP involvement is the typical presentation of the gout. And spinal involvement more common in osteoarthritis, that is spondylosis, ankylosing spondylitis, psoriatic arthritis, and reactive arthritis. And fibromyalgia rheumatica patient present with shoulder pain. And when the patient present with migratory arthritis, it may be rheumatic fever, gonococcal arthritis, meningococcal arthritis, viral arthritis, SLE, and acute leukemia. Acute leukemia and rheumatic fever are more common in pediatric age group. Now, we should also search for systemic condition like malaise, fever, night sweat, weight loss, myalgia, and fatigue. All these are more common in inflammatory arthritis. Now, we should start the number of the joints, whether the patient present with monoarthritis, polyarticular arthritis, or polyarthritis. Now, come to monoarthritis. When the patient present with acute monoarthritis, it may be bacterial infection, crystal-induced arthritis, and trauma. Among the bacterial infection, it may be non-gonococcal arthritis or gonococcal arthritis. Non-gonococcal, the most common is Staphylococcus aureus, maybe Streptococcus, and also gram-negative organism. Gonococcal arthritis, it is preceded by migratory tenosynovitis and skin lesion. Crystal-induced arthritis, it is acute presentation of the gout and situ gout and also trauma. And this is the typical presentation of gouty arthritis. This is also gouty arthritis involving the ankle joint, also soft tissue. And this is the presentation of the septic arthritis. And this is the gonococcal arthritis involving the MCB, PIP joint, and also tenosynovitis. Now, when a patient present with chronic monoarthritis, it may be chronic inflammatory monoarthritis, it may be chronic non-inflammatory monoarthritis. Among the chronic inflammatory arthritis, it is maybe tuberculosis, other infections of chronic gouty arthritis, and monoarticular presentation of the oligoarthritis or polyarthritis, that is, it may be rheumatoid arthritis or spondyloarthritis, and also sarcoidosis. But there are some uncommon causes like amyloidosis, foreign body, and pigmented bilionodular synovitis. In case of chronic non-inflammatory monoarthritis, most common is osteoarthritis and maybe also internal derangement due to trauma, and also chondromalacia patella, osteonecrosis, and some are uncommon or rare causes, that is Charcot Jones, which is more common in diabetic patients, sarcoidosis, and also amyloidosis. Now, osteoarticular arthritis, when the patient present with 1 to 4 joints. Typical presentation of the spondyloarthritis. Now, spondyloarthritis is a family which includes ankylosing spondylitis, psoriatic arthritis, reactive arthritis, arthritis associated to inflammatory bowel disease, juvenile spondyloarthritis, and also acute anterior uveitis is also included in the spondyloarthritis group. But why these diseases are classified together? Because they have some distinguished feature like inflammatory axial pain or back pain, asymmetrical oligoarthritis, sausage disease, that is dactylitis, and enthesitis. That means the inflammation at the site of enthesial attachment. And there are also some additional features like this patient have got genital and skin lesion. There may be anterior uveitis, and there is association with preceding infection or inguination, which is more common, and it is due to Salmonella, Shigella, Campylobacter jejuni, and they have a strong association with ACLA-B27. Now, when we call this is inflammatory back pain. Inflammatory back pain has some characteristics. Inflammatory back pain due to 4 out of these 5 criteria. That is, it should be onset should be less than 40 years of age. Morning stiffness should be more than 30 minutes, and it is more than duration more than 3 months. And activity improves with pain, and there is insidious onset, that not acute. Diffuse lumbar or gluteal pain, not focal or radicular. That is, focal pain is due to disc herniation. Now, how can you classify spondyloarthritis? According to ARSA's classification criteria, spondyloarthritis can be classified as axial spondyloarthritis or peripheral spondyloarthritis. Among the axial spondyloarthritis, that is non-radiographic axial SP ankylosing spondylitis, and on the other hand, peripheral spondylitis, undivided spondyloarthritis, psoriatic arthritis, reactive arthritis, but both of this group had considerable overlap. So it is termed to predominantly axial and predominantly peripheral spondyloarthritis. Now, we can diagnose, or according to ASA's classification criteria for diagnosis of spondyloarthritis. Now, for diagnosis of axial SPA, it has 2 arms. One is imaging arm, another one is clinical arm. In imaging arm, sacroiliitis, either X-ray or MRI plus 1 or more SPA feature. And on the other hand, in clinical arm, ACLA-B positive plus 2 or more SPA features. Now, what are the SPA features? This inflammatory low back pain, arthritis, anesthesial pain, uveitis, dactylitis, psoriasis, Crohn's disease, good response to NSAID, positive family history, elevated CRP, and ACLB27. And sacroiliitis is either by can detect by either by X-ray or MRI. Definite radiographic sacroiliitis actually modified newer criteria, that is mean class 1 or 2, or active marrow inflammation on MRI. It highly suggests of sacroiliitis in SPA group. Now come to ASA's classification criteria for the diagnosis of peripheral SPA. When a patient presents with peripheral arthritis, AN or enthesitis, AN or dactylitis, when uveitis, psoriasis, Crohn's disease, preceding infection, ACLB27 positive or sacroiliitis on imaging present, we need one or more SPA feature. But when the patient has got arthritis, enthesitis, dactylitis, inflammatory back pain, or family history, we need 2 or more SPA features. Now, you can see the comparison of spondyloarthropathy of the different presentation. That is ankylosing spondylitis, reactive arthritis, psoriatic arthritis, and inflammatory bowel disease associated arthritis. It is ankylosing spondylitis and psoriatic arthritis, reactive arthritis is more common in male, whereas psoriatic arthritis is more common in female, and IBD is male-female ratio is equal. It is onset is ankylosing spondylitis onset is more than 20 years, but psoriatic arthritis presentation may be any age, IBD also any age, and uveitis is more common in reactive arthritis. Among the peripheral joint involvement, ankylosing spondylitis and reactive arthritis, lower limb involvement is more than upper limb. Psoriatic arthritis, upper limb involvement is more than lower limb, and IBD lower limb involvement is more than upper limb. And sacroiliitis is more common, always present in ankylosing spondylitis, but in reactive arthritis, psoriatic arthritis may be present. Plantar fasciitis is more common in ankylosing spondylitis, reactive arthritis, and psoriatic arthritis. In ankylosing spondylitis, reactive arthritis, 90% cases is associated ACLB27 positive, and ankylosing spondylitis has good response to NSAID. Urethritis is more common in reactive arthritis, and conjunctivitis is also more common in reactive arthritis, and spinal involvement is common in ankylosing spondylitis. Now come to polyarthritis. Why is a patient present with polyarthritis? Maybe acute polyarthritis or chronic polyarthritis. Now when acute polyarthritis, it may be due to acute viral infection, early disseminated Lyme disease, rheumatoid disease, it may be rheumatoid arthritis or systemic lupus erythematosus or spondyloarthritis, but there are uncommon causes like paraneoplastic arthritis, acute sarcoidosis, adult steel disease, secondary syphilis, systemic autoimmune disease or vasculitis, and also Whipple's disease. In chronic polyarthritis, inflammatory causes most commonly rheumatoid arthritis, SLE, spondyloarthropathy, chronic hepatitis infection may be present with chronic polyarthritis, and sometimes it may be drug induced. But again, uncommon causes are paraneoplastic condition, systemic autoimmune disease or vasculitis, maybe Sjogren's syndrome. Non-inflammatory causes primary generalized osteoarthritis, hemochromatosis, and calcium pyrophosphate deposition disease may also sometimes present with chronic polyarthritis. Now I'll talk on acute polyarthritis, that is rheumatic fever, which is one of the common disease in our pediatric age group. For diagnosis of rheumatic fever, we have some major criteria and minor criteria. Among the major criteria, this is carditis, migratory polyarthritis, chorea, erythema nodosum, and subcutaneous nodules. And minor criteria: fever, arthalgia, previous history of rheumatic fever, raised ESR-CRP, leukocytosis, and first-degree heart block. For diagnosis, we need 2 or more major criteria, or 1 major or 2 minor criteria, plus evidence of streptococcal infection. But most of the cases, mistakenly, our inflammatory polyarthritis, oligoarthritis, we diagnose the patient as a case of rheumatic fever. But there is 2 things very important for diagnosis of rheumatic fever, or to differentiate rheumatic fever or other inflammatory disorder. One important that in case of rheumatic fever, arthritis does not present more than 2 or 3 weeks. On the other hand, our inflammatory arthritis usually persists more than few years or even more. And another thing, in case of rheumatic fever, deformity never develops. But if we find arthritis persistent more than 2 or 3 weeks or presence of deformity, it usually excludes acute rheumatic fever. Now, two important conditions of polyarthritis, chronic polyarthritis. One is rheumatoid arthritis, another one is SLE. We can diagnose rheumatoid arthritis by 2010 ACR or Euler classification criteria. There are four domains. One is joint involvement, another one is serology, another symptom duration that is less than 6 weeks or more than 6, and acute phase reactor that is ESR CRPI. For diagnosis of rheumatoid arthritis, 6 or more is present, then we can rheumatoid arthritis. And now you can see the new Euler ACR classification criteria for the diagnosis of SLE. Here we have two domains. One is clinical domain and another was immunological domain. Among the clinical domain, there are subdomains. There is constitutional feature, cutaneous domain, arthritis domain, neurological domain, serositis domain, hematological domain, and renal domain. And among the immunological domain, we have antiphospholipid antibody domain, complement domain, and highly specific antibodies domain. But before that, all patients classified having SLE must have positive ANA. That means titer more equal or more than 1:80. If ANA is positive, we should consider this domain. If ANA is negative, then we should search for other disease. Now, there is a simple algorithm for diagnosis of musculoskeletal pain. When a patient with joint pain or musculoskeletal pain, again we should initial rheumatic history or physical examination to determine whether it is articular, is it acute or chronic, is inflammation is present, or how many which joints are involved. If it is not articular, then we should consider trauma or fracture, fibromyalgia, polymyalgia rheumatica, bursitis or tendonitis. If it is articular and if the complaint lasts more than 6 weeks, that is chronic. If the complaint lasts for less than 6 weeks, it is acute. Then it is infectious arthritis, most commonly viral arthritis. It may be gout or pseudo gout, Hitter's syndrome, initial presentation of the chronic arthritis. On the other hand, if it is chronic, that it persists more than 6 weeks, is inflammation present? Is there is prolonged bonding stiffness, that is soft tissue swelling? Is there any systemic symptoms like fever, arthralgia, fatigue? Is ESR/CRP is high? If no, it is chronic non-inflammatory arthritis. That means it is maybe osteoarthritis, osteonecrosis, and Charcot joints. If if inflammatory features are present, it is chronic inflammatory arthritis. Then we should consider how many joints are involved. If 1 to 3 joints are involved, it is chronic monopolyarticular presentation, and consider indolent infection, psoriatic arthritis, Hitter's syndrome, polyarticular DIA. If more than 4 joint involvement, it is chronic inflammatory polyarthritis. If the involvement, then is the involvement symmetrical? If involvement is symmetrical, are the PIP, MCP, or MTP joint involvement? Yes, it is rheumatoid arthritis. If involvement is not symmetrical, it consider psoriatic arthritis, Hitter's syndrome. If MCP, PIP, MTP joints are not involved, unlikely to be rheumatoid arthritis, but you should consider SLE, MCTT, psoriatic arthritis, and also scleroderma. Now, how can we differentiate infectious joint pain? When a patient present with joint pain, we should search for fever, chills, myalgia, whether pain is constant, increased heat and swelling, and overlying skin is reddened, and whether this is polyarticular or monoarticular. If it is polyarticular, it may be viral arthritis, viral myalgia, viral arthritis, disseminated gonococcal infection, secondary syphilis, and also rubella or other infection. If it is monoarthritis, if it is in case of this monoarthritis, whether it is articular or periarticular. If it is articular and if it is acute onset, we should consider septic arthritis. If it is periarticular, it may be cellulitis, necrotizing fasciitis, septic bursitis, abscess, osteomyelitis, lymphadenitis, worse. And if it is articular, if it is insidious onset, it may be fungal or tubercular. Like in conclusion, I like to say our mind should be open during taking history, examination, and formulation of a differential diagnosis. Diagnosis of joint pain is mostly clinical. Proper history taken and physical examination is very important. Cost-effective strategy for lab tests depending on clinical database. Extensive investigation are not necessary. Routine lab tests before exploring clinical tools is wasteful. And this is my last slide. Thank you very much.
Thank you, Dr. Shamim Ahmed, for your brilliant presentation. Before going to second speaker, I like to announce that Professor Muhammad Mujibur Rahman, Head Department of Medicine, Dhaka Medical College, and Controller of Examination, Bangladesh College of Physicians, he also joined with us as a panel of experts. Sorry, sir, I didn't mention your name from, I know you joined here earlier. I didn't mention your name earlier. Now I like to request Professor Muhammad Nazrul Islam sir to present your topic. Nazrul sir will present on management of inflammatory arthritis. Nazrul sir, please.
Thank you very much, Shaheen. Are you listening me?
Yes, sir. Yes, sir.
Are you seeing me?
Yes.
দেখা যায়?
হ্যাঁ, তোমাকে ভালো দেখা, সুন্দর দেখা যাচ্ছে।
যে আজকের দিনটি আমাদের জন্য খুবই একটা ইম্পর্টেন্ট দিন, 12 অক্টোবর, ওয়ার্ল্ড আর্থ্রাইটিস ডে। আমি ধন্যবাদ জানাতে চাচ্ছি আমাদের শ্রদ্ধেয় শিক্ষকগণ এখানে এক্সপার্ট প্যানেল হিসেবে আছেন, বাংলাদেশ রিউমাটোলজি সোসাইটিকে to give me the opportunity to talk on this today's topic. And parallelly, I would like to thank the BD physicians as well as the SKF. They possibly sponsored the program, and of course, not in least the participants who are here to spend some time with me. My talk is on the management of psoriatic arthritis. Of course, you know, I would like to say something new. Are you working? Oh, here I have to click. Oh, yeah. Before decide to treat a case, I think everybody will know we need to have some considerations about the particular disease. There are many things to tell about the psoriasis and the psoriatic arthritis. We know psoriasis is not a single disease. Psoriasis and the psoriatic arthritis, some of the time psoriasis comes early, and years after the patient can develop the psoriatic arthritis. Then we say it's a psoriasis and psoriatic arthritis. Some of the time only psoriasis is an issue. So and then patient can present at the very beginning with the arthritis, and subsequently patient can develop the psoriasis. So it's a spectrum. We need to take care of that before treating the case. So I think many I will not say about the burden, but important aspects we need to consider nowadays. Why psoriasis we are considering in a different way. So there are many comorbidities and having a higher prevalence with the psoriasis, starting from the rheumatoid arthritis, metabolic syndrome, diabetes, Crohn's disease, respiratory system disease, obesity, together with, and here you are seeing there are the higher prevalence of this comorbid illness in a big population of psoriatic patient. And not only that, interestingly, there are several comorbid illness related with the psoriasis severity. So no psoriasis to that of the severe psoriasis. So these are the comorbidities like COPD, diabetes, and diabetes complications, liver disease, MI, peptic ulcer disease, peripheral vascular disease, renal disease, and rheumatological diseases related with the more the severity of the psoriasis and then the psoriatic arthritis, and more the comorbidities related with that. Other important aspects nowadays we are talking, we know many of the things coming up with that. Psoriasis is not only a problem, a simple problem. It is related to depression, anxiety, suicidality. There are many evidence with that. The cytokines are related with the psoriatic patient with the depression, anxiety, and as well as suicidality. And interestingly, it is higher in the men and also in the younger age group. 30 to 45% have higher risk of depression, anxiety, and the suicidal tendency. So we need to take care of this illness as a whole. so that we can address many of the things. Interestingly, obesity plays an important role in the outcome of the psoriasis patient. If we treatment success depend on the BMI of a subject. Lower the BMI, higher success rate, and the higher the BMI, less success rate of treatment. So that's again an important aspect we need to keep in mind. If we look at to the pathophysiology of the psoriasis and the psoriatic arthritis, here there are the interesting cells and the cytokines related with that. Your T helper cell 1 and 17 upregulation, T helper 2 take with dysregulation, TNF, interleukin 1, 6, 8, 17, CRP, leptin, and the ICM. These are the different cytokines, interestingly present both with the psoriasis and psoriatic arthritis, and they are also play a role in the development of CVT and also the metabolic disease. Now question comes, psoriasis is a simple disease or a isolated disease or a systemic disease? I hope with this brief information, it is clear to you psoriasis is a systemic disease. So we need to think the psoriasis in that way. Interestingly, there are challenges with the lab test interpretation not only in psoriasis, in the SPA as well. So sometimes it can happen, the lab test can turn out normal and the patient may become unhappy as because she is a sufferer. So let us have a look, what are the problems lies with the lab studies. It may be normal, and elevated ESR, sometimes we get in the 40% of the patient. Interestingly, rheumatoid factor and the ACPA can be detected in less than 10% of the cases of psoriasis. Once there is a generalized skin lesion, subjects with psoriasis 10 to 20% can have the higher uric acid level. If you do the synovial fluid analysis, they are a higher WBC count, and more than 50% can have the polymorphonuclear leukocytes count, so can mislead you whether it is a infective disease or a inflammatory one. Before start the treatment, we need to have some information about whether the disease, the person does have a poor prognostic factor or not. These are higher number of inflamed joint, elevated ESR CRP, failure to previous medications, joint damage clinically and radiologically, and loss of function by HAC, and diminished quality of life. So if someone does have these poor prognostic factor, we need to consider them differently. It will be clear to you in the subsequent slide. And interestingly, psoriasis does have multifaceted presentation. So it has the peripheral arthritis, some axial component, enthesitis. Sometimes this all can be together, dactylitis, the toes, fingers like that. Sometimes enthesitis, these are the picture of the enthesitis, Achilles, behind the Achilles. And here the skin and the nail changes are there. So of course, we need to take care about the eyes so patient can develop the uveitis with the patient of psoriatic arthritis. So these are the considerations. I think it will help us to individualize our cases while managing the or evaluating the psoriatic patients. So that's why we need to have a holistic approach when we are deciding to treat a case of psoriatic arthritis. So we need to fix a goal, and then we have to assess the patient. Already I have mentioned it does have different domains. So and then the comorbid illnesses. So in that way, we have to have the clinical assessment we need to do. So about the comorbid illnesses, we have to note, and then treatment decisions, we have to talk with our patient to assess their ability to disease course and so and so. Then, and of course, not only giving the treatment, we need to assess the outcome of the treatment as well. Of course, if we need to have a success, we need to have to counsel our patient. But in psoriasis and psoriatic arthritis, it is the one cardinal talk, at least we need to say, is not a contagious. So we need to bring them into the mainstream of the life. There are several trigger factors, everybody we know, related with the psoriasis. If someone has the psoriasis and the psoriatic arthritis, several trigger factors. So we have to address the stress, infection, other illness, and the smoking, tobacco use, of course, injury, sunburn, alcohol, drug reactions. These are the things very important. And the other way, if we give up the we have to address the infection. Vitamin D deficiency, again important for that. And there are some drugs. Of course, sometimes myself and others also have a look. Some of the patient gets the antimalarial and the steroid as well. These are the trigger factors. So we have to avoid this thing as much as we can. Nowadays, so there are several biologics and DMRs we use to treat this case. So that's why vaccination, different bodies advocate this one in different way. CDC also advocate many other vaccines, but I think at least we can consider these vaccines in our patients before starting the biologics and the DMRs. So the kill vaccine, pneumococcal influenza, hepatitis B, and the less than 26 years of age up to recombinant human papilloma virus, and live attenuated herpes zoster vaccine. We don't have this one in our country. And if someone needs this vaccine and already received the DMRs, the biologics, they are candidate of the kill vaccine or the recombinant one. And if herpes zoster vaccine should not be given, who received the biologics? So now with this information, let us have a look. I just bring here only one guideline algorithm in front of you. This on the Euler. A little attention I would like to see from you. So about this one. So if they have divided in different phases, I'm talking about the phase 1. So here, if clinically someone, we make a diagnosis of active psoriatic arthritis, then you have to consider how many joints involved, polyarticular or monoarticular, enthesitis present or not, and whether predominantly axial or not. So if someone monoarticular, then we need to look for the poor prognostic factors.
স্লাইড শো দাও মনে হচ্ছে, স্লাইড শো দাও মনে হচ্ছে।
আমি তো স্লাইড শোতেই আছি।
এটা শুরু দেখা যাচ্ছে কেন? দেখো তো শুরু দেখা যাচ্ছে কেন?
এটা স্যার স্লাইড শোতে আছে স্যার।
স্লাইড শোতে নাই, পাশে স্লাইড দেখা যাচ্ছে, নিচে ছাতার মতো একটা জিনিস আছে, ওখানে ক্লিক করলে শোতে চলে যাবে।
এই আরো নিচে
এই যে, হ্যাঁ ওইটা yes, now it is show.
So if it is
thank you
monoarticular, if it is a monoarticular, then you have to look for the poor prognostic factors, and then if they're present, then the treatment, if not and if present, if not, then the NSAIDs and local glucocorticoid injections. Then we have to look it for the improvement is within the less than 4 weeks. If we observe the improvement, then we can continue and adapt. So if the polyarticular one is straightway and also monoarticular is the poor prognostic factor, they are the candidate of phase 2 treatment, and that is the methotrexate, leflunomide, and the sulfasalazine. If enthesitis is there and the predominantly axial disease, then NSAIDs glucocorticoid at the very beginning, then we have to observe the case for the 4 to 12 weeks. If improvement is there, you have to continue and adapt. If no improvement, then we have to go for the phase 2. And then if we start with the methotrexate, leflunomide, of course, this is one after another. The first drug is the methotrexate. If we observe for the 3 months of improvement and then target achieved in 6 months, we have to continue this one. If no, then the phase 3. Phase 3 tells us to start the biologic DMRs, TNF inhibitor, interleukin 12-23, interleukin 17 inhibitor. If biologic DMRs inappropriate, start the JAK inhibitor. You know, we do have many drugs in our hand now, and if it's the enthesitis and the predominantly axial, then we have to start the biologic DMRs, TNF inhibitor, interleukin 17 inhibitor, and the usual practice would be the start with the TNF inhibitor. So 3 months again, we have to observe, and we have, if remission lasts for the 6 months, we have to continue the treatment. If no, then arthritis and or enthesitis, and on the right hand side, which is the predominantly axial disease. So it is a phase 4. We have to switch to another biologic DMRs or JAK inhibitor or the PDE4 inhibitor within or between classes. Then here also we have to switch to the biologic DMR within or between the classes of TNF inhibitor and the interleukin 17 inhibitor. So again, we have to observe this case for the 3 months and the target achieved. At the six months, we have to continue that's one. If no, and again, arthritis and enthesitis or the predominant axial disease. So these are the biologic DMRs, JAK inhibitor, phosphodiesterase 4 inhibitor, and the switch to another biologic DMRs within or between TNF inhibitor or interleukin 17 inhibitor. So same thing, 3 months observation, target achieved for the 6 months. We need to continue the treatment. Here the same thing, need to continue the treatment. But if not, we have to go back. That means the another drugs, what we do have in hand, we need to try this one. So some information, I think we do have some participants there. They may be interested with the methotrexate use. A little information I will give you. Now we know much better about the different cytokines. It plays a role and there's the interrelated to each other. That is why the same drug effective in the several conditions in rheumatic illness. So methotrexate, how it works? It acts by inhibition of the inflammatory cells proliferation and interfere the T cell activity and cytokine secretion. The outcome is the decreased release of inflammatory cytokines, TNF alpha interleukin 6, and the higher release of the anti-inflammatory cytokines, interleukin 10. So this is a little summary how methotrexate work, but there are some absolute contraindication of using the methotrexate. Anemia, somehow I say it is less than 7 grams per day. Leukopenia less than 3,000. Thrombocytopenia less than 80,000. Disease is very important. We need to take care about the nowadays methotrexate users. We need to take care about the eGFR if it is less than 40. Pregnancy, desert pregnancy, lactations are the other absolute contraindications of methotrexate use. So before giving this drug, we simply do the CBC, creatinine, SGPT. If SBS is if other needed symptom are there, X-ray chest and albumin can be done. Here in the right side, if the patients if there are many comorbids in the with the psoriatic arthritic patient, so this if needed, these investigations can be done at baseline. So how to start with the methotrexate? So the lower dose, 7.5 to 10 milligram can be used. Sometimes we can start the higher dose. So this is again based on the physician can choose which one they select. So higher dose, we need to take care a little as because if we start with the higher dose, so stomatitis, nausea, GI intolerance can happen in some of the cases. And one thing we need to keep in mind, in oral methotrexate, if dose is more than 15 milligram, good to divide in a 12-hour dose in the same day to have the better bioavailability. And we need to monitor the cases. So monitor means the two part, one is the response, another is the toxicity. So there are some parameters, the psoriatic arthritic patient with the joint count, pain severity, HAC, then DAS28 we can use for the your efficacy parameter, and adverse effects starting from the GI, your hair loss, urticaria, headache, cough, dyspnea, depression, and the opportunity infections we need to take care. What are the tools we do have? ESR CRP basically helps us to understand whether patient improving or not. And for toxicity, CBC, already you know the cell count may be depressed by the methotrexate, AST can go up, creatinine can go up. So other tests, depending upon the presentations of the patient, we can do. Next thing can come up, how to titrate the dose of methotrexate. So it's a 5 milligram increment in 3 to 4 weeks. So a maximum dose of 25 to 30 milligram per week we can give depending upon the clinical response and the tolerability. So some of the time when we are treating our case, we need to stop methotrexate treatment. So severe GI upset is there. If dizziness is there, more than 3 times upper limit of AST from baseline, and the total count less than 3, these are the absolute contraindications what I said you before starting the methotrexate. So if something comes to anyone, we need to stop methotrexate. We have to evaluate the case, and if dire need to continue with the methotrexate, the challenge can be done slowly. For GI upset, what better we can do? We can give it for at the bedtime. Supplementation of folates can help us. Dose splitting can help us. If side effects is the issue, we can switch it to the subcutaneous and the intramuscular one. And folate supplement is the must. All patients should receive folic acid 1 milligram per day or 5 milligram per week, except the day of methotrexate. Folinic acid, it is available in our country as well, 5 milligram 12 hours of the last methotrexate dose. And now this is about the little about the methotrexate. I'm just talking now about the biologics, a small molecule, as because these are the agents available in our country. So here, these etanercept, infliximab, golimumab, adalimumab, all are available in our country. IL-17 is also secukinumab available in our country, and the PD4 inhibitors, apremilast also available, JAK inhibitors, several tofacitinibs are now in market. So once we are deciding to treat our case with these biologics and the small molecule, we need to have a pre-biologics therapy assessment. So tuberculosis screening, how we can do by tuberculin test, and if better and best is to do the interferon gamma assay. What we know that your quantiferon TB gold test and hepatitis B, C screening good to do, and the other markers we need to we can do to evaluate this one. If HIV is a suspected one, we need to you need to check that. We need to check about whether patients are vaccinated or not. These are the a little cardinal information about the safety concern of the different your biologics and the other drugs, at least TNF inhibitor and the IL-12, 23, 17, similar type of risk lies behind of it. So these are the agents contraindicated in patients with serious active infection associated with the increased opportunistic infections. Reactivation of hepatitis B or TB infection can happen associated with the development of the malignancies. This is again, this one a little, I think we can omit this one as because now literature came us in our hand, there's no relation with the malignancy. And these other two agents are similar, infections and your malignancy risks. We need to further time to know about the malignancy risks with the IL-12, 23 or 17 drugs. Apremilast, everybody knows diarrhea is the most important one. It can cause depression and upper respiratory infection as well. In Bangladesh, I think we do have many experience of using this one. I am trying to show you some of the study, what we have done. 2015, when the drug etanercept came in our country, we decided to do a study to see whether it is effective or the risk of tuberculosis. This one published in the International Journal of Infectious as a abstract. So I am showing you only the your psoriatic arthritis component. This one, what we did, we determined to determine the efficacy of 50 milligram etanercept every 15 to 21 days interval, and to observe the risk of tuberculosis and other infection. Interestingly, in that series, only 15 patients was the psoriatic arthritis, and out of the 15, 4 didn't continue, and about the 11 patients, 2 completed 1.5 year, and the 3 completed 1 year, and 6 completed the 3 months, and none developed TB or serious adverse event. And with these two ESR CRP and the BASDA I am showing you, so the agent was found effective at 3 months. So from baseline to the 3 months, both in terms of the markers and as well as the disease activity, and they persist for efficacy persists for the months. What about the drug needed to treat this case? So these are the 50 milligram, 36%. These are the 100 milligram, 36%. 75 milligram is the 9%, and 150 milligram is 19%. So it says us the lower dose with at least with 100 milligram in a month, if we use etanercept, we can treat 80% of the case suffering from the psoriatic arthritis. And further information I will tell you about how effective in etanercept effective in psoriasis or not. So tofacitinib in psoriatic arthritis, everybody it received the recommendation both by the ACR and the Euler. Appler also given the recommendation, and it is for psoriatic arthritis. This is the important one, not recommended in combination with biologic DMRs or with potent immunosuppressants such as azathioprine and the cyclosporine. So I would like to thank our some beloved students. So they did some study. The Dr. Prayush Sharma, he did a study, his thesis, safety and efficacy of tofacitinib versus methotrexate in the treatment of psoriatic arthritis and open label randomized study. For time constraint, I will inform you the efficacy, the results only, and the side effects. So the Asadul Islam, again, he did a study, efficacy and safety of tofacitinib in the treatment of NSAIDs refractory axial spondyloarthritis, a clinical trial. Why to show these studies? As because we are using tofacitinib, we need to have some idea how safe it is and how better to use in our clinical practice. So this one my study, this one ongoing study. A part of the study we have presented as the pilot in the 2018 APLAR conference. There we have in the clinicaltrial.com, you can have the methodology. I will not detail the methodology. Still the study is going on. So the tofacitinib versus lower dose etanercept. About the lower dose I mentioned you. So the from what are the observations we learned from the studies? All studies reported that 10 milligram tofacitinib was effective in refractory SPA and psoriatic arthritis. A comparable efficacy was observed with both control drugs, methotrexate, and the lower dose of etanercept. The 6 months results of the tofacitinib versus lower dose etanercept in our country. So some information I am sharing with you. We have objectives to see that tofacitinib, to compare it with the lower dose of etanercept. Of course, I will tell you about the psoriatic arthritis. Tofacitinib 10 milligram we have given a day, etanercept 50 milligram weekly in the first month, then 2 weeks interval in the second and third month, then every 3 weeks interval we are using this agent. Clinical lab assessment done in the 3 and 6 month interval, and let us have a look about the result. So very interesting, many of the dropouts was with that pilot one. So in group A, 32 patients were, and the group B, 50 patients we got, and that's the comparison are done. TST was positive in the 14 patients, 7 is each group, all were quantiferon TB gold test negative and normal chest X-ray. If you look at the efficacy from that study, it is showing CRP and the ESR, and the blue bar on the CRP. Here is the BASDAI and the group A and group B. So it shows us the drug found to be very effective from baseline to the 6 months, and similarly in the both the drugs were effective. But interestingly, if you look at the bar, possibly it is not statistically significant, but CRP reduction is more marked with the etanercept group. The important aspects of while managing the psoriatic arthritis, we need to take care of the uveitis as well. So we try to look at the uveitis and the enthesitis and the dactylitis we didn't analyze. So that's one uveitis. None in the tofacitinib group develop uveitis. So it gives us the information. It may be effective in managing the uveitis of psoriatic arthritis as well. And with the etanercept, 2 patients develop uveitis. So it says us for severe psoriasis and patient does have the uveitis, etanercept is not a good choice for that condition. Now about the side effects. So the most of the side effects are related to the tofacitinib group, and out of them, the gastroenteritis is the important one. Next to that is the dyslipidemia, and in the etanercept, that is the upper respiratory infection is the problem. So the infection rate is higher with the tofacitinib group. About the tuberculosis, from these all the 3 studies we have done, Prayush Sharma didn't find any problem, but in my study, we used the tofacitinib in this patient with the 15 milligram when it didn't respond to the usual 10 milligram dose, we made the increment of 15 milligram. He responded, but at the end of 9 months, he developed tuberculosis, tubercular limb adenitis. And the Dr. Asad, in his study, he has given the patient had latent TB. He treated the case and then started treatment. And with the 20 milligram of tofacitinib, the one case has developed disseminated tuberculosis at 6 months. So it says as again from this slide, I would like to say this is the warning, and of course now the recommendation as well. The not to use more than 15 milligram tofacitinib. I think this is more justified guideline from the FDA as well. And I am just again another question here, whether latent TB tuberculosis is enough for our subject or not. That's the question. With the adverse event occur where the tofacitinib group only with the severe adverse event, they need to be in hospitalized. So these are pneumonia, anemia, cellulitis, UTI, diarrhea, and hepatitis C infection. So at 6-month evaluation, what is our impression? Both tofacitinib and lower dose etanercept were effective to treat the refractory SPA, of course in psoriatic arthritis as well. Though not significant, CRP reduction is more marked. Why I am saying about the CRP? Everybody, you know, the CRP is a marker of cardiac insult and injury, and that of the psoriasis and psoriatic arthritis, we do have a lot many comorbidities, including the cardiac risk. So that's why the important. Infection and dysarthria are more frequent in the tofacitinib group. Higher dose, more than 15 milligram, may not be safe in this group. So a little information about the IL-17 inhibitor. Professor said Atikul Haq sir, he is using a lot many cases, but I do have only case, 2 cases I am following with the psoriatic arthritis. It is available. Cosentyx is the trade name. Subcutaneous injection, pre-fill injection comes up. So at a dose schedule is that those who are TNF naive, they are the 150 milligram needle, 5 needle in the first month, then 150 milligram single needle monthly as a maintenance. And those who are inadequate response to the TNF exposure, they do have a 300 milligram dose, the same thing, 5 needle in the first month, then monthly maintenance. What about the efficacy? So this future study, they have shown the overall TNF naive case and TNF inadequate response. In that case, they have shown the ACR20 about 77%, and about the ACR50 about 55%, and ACR70 about the 33%. And naive cases having a little higher response, but those who are exposed to the TNF inhibitor, they have a lesser response comparison to the naive subjects. And they have shown the efficacy of that drug with the dactylitis and as well as the enthesitis as well. So it tells us that if someone a candidate of your secukinumab, then we have to think that if someone has the enthesitis, someone has the dactylitis, and as well as the we don't know information about the uveitis and the nail changes. That's the different aspect. But this subgroup of people is good to be a candidate of the secukinumab from the very beginning, rather than trying TNF blocker first, then the secukinumab. So it does have some adverse effect. Upper respiratory infection is the most common one. Then the very common. Then next common is the oral herpes, diarrhea, urticaria, and rhinorrhea. Uncommon is the candidiasis, neutropenia, tinea, and conjunctivitis. I would like to acknowledge my students and my co-workers. They are working with me to do this study. Thanks a lot. Thanks for your patience hearing.
Thank you, Professor Mohammad Nazrul Islam sir, for your most informative and brilliant presentation. Now this is the time for question and answer. Due to time constraint, there is no scope for further question. Already 35 question in my hand. I see in the question and answer box. But it is announcement is that there are 3 attractive prize gift for 3 best weighted question. But I don't have 35 prize. I have only 3 prize. Here question is 35. Now I like I seek suggestion from chairperson as well as panelists, my respective teachers, how I will select 3 questions. It is not possible to ask all the questions or answer all the questions. At only 2, 3, or 4 questions it is possible to allow. So if I am allowed to select the question, then I can do. But what is your suggestion, my dear respective teacher, Professor I am Jalil Chaudhary sir? How should we select?
প্রশ্ন করে উত্তর দিয়া করা সম্ভব না।
ফ্যামিলি এবং অনেকগুলি কোমরবিড আছে। যদি কোমরবিড অনেকগুলো থাকে সিভিয়ার ডিজিজ থাকে তার বলে হয় এই পেশেন্টকে ধরে রাখা ঠিক না, এই পেশেন্টকে রিউমাটয়েডের কাছে পাঠানো উচিত। যদি মাইল্ড ডিজিজ থাকে, অল্প দিয়ে একটা জয়েন্ট ইনভলভমেন্ট থাকে, সো ইউ ক্যান ট্রাই উইথ দ্য NSAIDs and at best with a good knowledge with the methodic set you can try. If you see it is a problem for you, then straight away you can refer.
থ্যাংক ইউ স্যার। আরেকটা অনুমতি দিলে স্যার, আরেকটা লাস্ট কোশ্চেন শামীম ভাইয়ের কাছে ছিল, হোয়েন টু রিফার নিউরোলজিস্ট অর নিউরোসার্জন ফর লো ব্যাক পেইন। এটা লাস্ট কোশ্চেন। যদিও এই 4 জনের মধ্যে স্যার প্রথম 3 জনকে আমি সিলেক্ট করেছি, স্যার আপনাদের কোনো অপিনিয়ন থাকলে 4 জনের মধ্যে আপনারা একটু শিফট করে দিতে পারেন। এই 4 জনের মধ্যে স্যার আমাদের কাছে 3টা প্রাইজ আছে, 3টা প্রাইজ হচ্ছে মূল্যবান প্রাইজ। এই প্রাইজটা আমি আমাদের প্রেসিডেন্ট দিবেন। প্রাইজটা হচ্ছে, আমি একটু যদি স্যার বলেন আমি বলে দিতে পারি নামটা কি প্রাইজ। প্রাইজটা হচ্ছে আমাদের আজকের চেয়ারপারসন জলিল চৌধুরী স্যারের ওসপি যে স্যার যে বই লিখেছেন সেই বইটা, যেটা আমরা আমাদের কাছে খুবই মূল্যবান, সেই বইটা আমরা দিচ্ছি। তো শামীম স্যার আপনি বলেন, আপনার উত্তরটা একটু দেন।
আসলে লো ব্যাক পেইনের ক্ষেত্রে আমরা কখন নিউরো সার্জনের কাছে রেফার করব, তাই তো? আসলে সব পেশেন্টকে আমাদেরকে আসলে রেফার করার দরকার নাই। যখনই আমরা দেখি কডাইকুইনেস সিনড্রোম পেশেন্টে ডেভেলপ করছে, অথবা মেজর উইকনেস আছে, মোটর উইকনেস, অথবা প্রোগ্রেসিভলি পেশেন্টের হলো মোটর উইকনেস আছে, সেই ক্ষেত্রে কিন্তু আসলে সার্জিক্যাল ইন্টারভেনশন যদি করতে হয়, সেই ক্ষেত্রে পেশেন্টের আমাদের নিউরো সার্জনের কাছে রেফার করতে হবে। তো ফার্স্ট কথা হলো, যদি কডাইকুইনেস সিনড্রোম যদি ডেভেলপ করে, দ্যাট মিনস বাউল ব্লাডার যদি ইনভলভ থাকে, তাহলে পেশেন্টকে আর্জেন্টলি আসলে নিউরো সার্জনের কাছে রেফার করতে হবে, অথবা মেজর ট্রমার কোনো যদি হিস্ট্রি থাকে, অথবা মেজর মোটর উইকনেস যদি থাকে। এই 3টা কন্ডিশন থাকলে কিন্তু আমাদের আসলে নিউরো সার্জনের কাছে রেফার করা উচিত। আর আরেকটা ক্ষেত্রে দেখা যায় যে আমরা যদি কোনো একটা পেশেন্ট আসলে লো ব্যাক পেইন নিয়ে প্রেজেন্ট করে বা রেডিকুলোপ্যাথি নিয়ে প্রেজেন্ট করে, সেই ক্ষেত্রে ম্যাক্সিমাম ক্ষেত্রেই কিন্তু পেশেন্টের আসলে এই পেশেন্টের সিম্পটমের সাথে আসলে এমআরআই ফাইন্ডিংস এ আসলে ডিসক্রিপেন্সি দেখা দেয়। কারণ অনেক কিছুই কিন্তু এমআরআই ফাইন্ডিং এ আমরা আসলে এই অ্যাসিম্পটোমেটিক পেশেন্টেরও পেতে পারি। কাজেই সব পেশেন্টদেরকে কিন্তু আমাদের নিউরো সার্জনের কাছে রেফার করার দরকার নাই।
থ্যাংক ইউ শামীম ভাই। এখন আমরা আমাদের প্যানেল অফ এক্সপার্টস যারা স্যাররা আছেন, আপনাদের মূল্যবান সময় আজকে এখানে আমাদের সবার জন্য দিয়েছেন। আমি শুরুতে একটু আমাদের প্রফেসর টিটু মিয়া স্যারকে রিকোয়েস্ট করব, স্যার কিছু কমেন্ট, আমাদের যারা আজকে অনেক পার্টিসিপেন্ট দেশের বাইরে থেকেও অনেকে যোগদান করেছেন, স্যার আপনি তাদের উদ্দেশ্যে একটু যদি বলেন আমাদের স্পিকারদের বক্তব্য এ সম্বন্ধে।
Shahin. Respected chairperson, my teacher, Professor Jolil Choudhury sir, and my dear colleagues and teachers of today's other panelists, and the honorable participants. And my special thanks to the organizer for selecting me as a panelist. And I'm really proud of, and I must say congratulations to the 2 brilliant speakers, because they have narrated their speech very nicely and started with informations, with latest informations. And I'm sure all the participants, including me, has been refreshed our knowledge from their talks. Regarding, I think at the eve of this World Arthritis Day, they have left no stone unturned about the talks in their topics. And what I want to say regarding the diagnosis of the approach to patients with arthritis is the main thing is to reach the accurate diagnosis. And for the accurate diagnosis, we must have the speakers, Mr. Shamim, Dr. Shamim has very nicely narrated. The prerequisite of the accurate diagnosis is the elaborate history taking and clinical examinations. And mostly the accurate diagnosis is reached by these 2. And investigation should get the minimum priority, as minimum as possible. Because if the investigations is enormous, then the clinical examinations and the history taking, then the diagnosis will be in dilemma, and the patients we will be confused. So clinical examinations and and the history taking should get the priority. And regarding the normal findings in the patients having the acute inflammatory arthritis, Professor Nazrul sir very nicely mentioned, sometimes the inflammatory markers or investigation might be unrewarding. The normal. In that very situation, psoriatic arthritis is a good differentials, But I also like to say the chronic viral arthritis also should come in our mind, and especially the chikungunya in our country. We used to get so many cases, and every one of us is facing the problem. The patients has got the enormous amounts of the very severe arthritis, but without the investigation is unrewarding. And in that very situations, the chronic chikungunya arthritis should get the, in mind, and also in some cases of the other spondyloarthropathy should come into the mind. Regarding the treatment management of the arthritis, especially the psoriatic arthritis, yes, sir has very nicely mentioned the methotrexate should be the first choice of the drugs. And before starting what I used to prefer in difficult cases who does not respond with the methotrexate, tofacitinib is rather a very good choice for me, and I prefer, because most of the patients could not afford the biologics and other things, and we find the safety profile of the tofacitinib is very, not that much toxic, or the side effects is not that much. So it is rather we can prefer before switch over into the biological agents. And all of us should follow the rule. The patient should be vaccinated, and before starting the biologics and the tofacitinib, JAK2 inhibitors, we must be submitted the patients for the latent tuberculosis, and also for the hepatitis B virus and C virus investigations. And finally, I like to say I have got no experience about the IL-17 inhibitors, but in refractory cases, yes, it will be promising, and we can start these sorts of drugs we can prefer. And finally, I like to thanks again the speakers, and also the today's organizer, and also the sponsors probably, and also the doctors, those who are involved in the technical support of these sessions. And finally, I like to thank the moderator of the session, who has very nicely moderated the session. Thank you very much.
Thank you, sir. Thank you, Professor Titumia, sir. Now I'd like to request Professor Minhaj Rohim Chaudhuri, our one of the panelists. Sir, please say something for us.
Dhanyabad, Shaheen. So there is time constraint, and আমরা তাড়াতাড়ি আমি শেষ করার চেষ্টা করব. Respected chairpersons and the respected panelists, including me, and I am thankful to organizers. And so the presentations, we had two presenters, and they presented very nicely. Their presentations were brief, comprehensive, and definitely illuminative. I myself learned a lot from their presentation. Just 2 points for the those who are here, especially our students and the junior doctors. For them, I would like to request if you pick up few points. So there are lots of information, lots of knowledges from their deliberation. But if you pick up one, I'd like to request you pick up one from Dr. Shamim's lecture, and that is to differentiate the acute rheumatic fever from other form of arthritis. So it's a common thing in Bangladesh, especially in periphery. We find the rural practitioners, they always consider that one is having some joint problem or pain somewhere in the body. They think it is acute rheumatic fever, and they will ask the patient or the party to do some ASO titer, and they will say, yes, you have rheumatic fever, we'll start injection penicillin. So just 1 point you need to remember: in acute rheumatic fever, the joint pain will not persist for more than 1 month. So if it persists, joint pain or joint swelling or like something so related to joint, if it persists for more than 1 month, you consider this is very unlikely to be acute rheumatic fever. This was the message from Dr. Shamim's presentation. And definitely if it is beyond 3 months, very, very unlikely. Beyond 6 months, it is impossible to be rheumatic fever. In that way, you should think of. And the second presenter, Professor Nazrul, if you pick up one thing, already Professor Titumia told that is very important that in our perspective, we will start with methotrexate definitely. And Professor Nazrul Islam showed that if we look at the recommendations of the EULAR 2019, the latest recommendations, so their recommendation, if we look at the flow chart, first start with methotrexate or sulfasalazine or leflunomide. We usually start with methotrexate. You just remember one drug, methotrexate. And then if it doesn't work, then in Bangladesh perspective, we will put our patients on tofacitinib definitely. And vaccinations and the latent TB screening is very important. Already Professor Titu told. And then we will switch over to biologics. But if you look at the flow chart by the EULAR 2019, or even they had recommendations before also, they recommend MTX and then they switch over to one biologics like TNF inhibitor and then secukinumab. Now the 2019 recommendations, they have recommended that anyone, either TNF inhibitor or secukinumab also may be chosen. And then they recommend for the tofacitinib, the small molecule, because this drug is very expensive in Western world, even in India. But we are very lucky that we are getting it in a cheaper rate. And we should definitely, prior to prescribe our patients, we should keep it in mind that it has got several side effects. And with these few points, again, I'd like to thank the organizers, especially our organization, Bangladesh Rheumatology Society. And we are very proud to have this kind of program with BD physicians. And in future, we hope this collaboration will be continued. Thank you, everybody, for the participation.
Thank you, Professor Minhaj Rahim Chaudhary, sir. Now I'd like to request Professor Dr. Mujibur Rahman, sir, to say something regarding today's presentation.
Thank you. Thank you, dear moderator, for your very nice and well-organized moderation. I also would like to thanks to the Department of Rheumatology, BSMMU, and the BRS for organizing such an important and illuminating sessions for us, especially for the trainees and the residents. Thank you again for including me in the panelist, but this is not the time to say something specially on the topics. The topics are well covered by the two renowned speakers, Professor Nazrul Islam and also Professor Shamim Ahmed. So it would be very time consuming to say anything over this topic. So I would like to extend my thanks to them for covering these subjects in detail for us, for our understanding. And Mr. Chairman, sir, thank you for extending your books as these sorts of question, not for the answer, but for the questions. And again, there is no gift or prize for the speakers also. It ekta bhalo dik is a good thing that we should encourage the juniors to ask the questions in these sorts of seminar. So I would like to express the my heartfelt thanks to all the panelists and also the attendees for whom the program is intended to have some impact over their learning process. So thank you very much. কিছু বলবো না বলেও দেখা যায় যে অনেক কথা বলে ফেললাম. Thank you very much. Thank you.
Thank you, Professor Mujibur Rahman, sir. Now I'd like to request my respected teacher, Professor Dr. Kaji Tariqul Islam, sir, for your comment. Please, sir, say something for us.
Oh, this is near midnight, so I should not bother people. This was an excellent session. Being an internist, we used to handle a lot of rheumatic patient, this connective tissue disorder patient. And sometimes there was one question to Professor Nazrul, when to refer. Is excellent. And one internist should know when I should refer the case to rheumatologist. And today's seminar gives this smell, this message that at some point the internist should refer the case to a specialist where the patient can be handled better. So, Mr. Chairman and speakers and panelists, I'm very grateful that I have learned a lot today. At least many of the things that exercised again, and the recapitulation of my mind took it very nicely. One or two things I will just touch. Number one, Shamim give a very masterly presentation as if we are in a class of rheumatology. It was very nice approach to a case of arthritis. How we can differentiate? I think our students, postgraduate students, they got a lot of benefit from this. And very nicely he dispensed inflammatory, non-inflammatory, and so on, so on, so on. So this is very wonderful, and obviously this helps us. And we were not knowing, at least I was not knowing, that rheumatological problem is almost 8 times more than diabetes. In his slide, it is shown. So it is a huge burden for the nation. For if it is the data from United States, almost it will be in Bangladesh like the same. And with age, who is not having aches and pains and so many things, arthralgia, arthritis, everything, osteoarthritis. So বয়স বাড়ার সাথে সাথে এগুলো সবই হয়। আমাদের we are very much thankful যে we are in this today from the lectures of Shamim. Regarding Professor Nazrul, it was amazing because regarding psoriatic arthritis, he told everything with a very short period of time without going into very much detail, but took the main points for the listeners. And the association with the other systemic disease like COPD, diabetes, kidney disease, depression, suicide, many things he told. But this is very important. Obese people is having much more prone. But one thing, last one point I will tell, because Dr. Titu and others, they told the same issues, that tofacitinib or JAK2 inhibitor is a very safe drug, comfortable. মেথোট্রিক্সেট দেওয়ার পরে যেমন বারবার 3 মাস পর পর এগুলো চেক করা লাগে, ফলিনিক অ্যাসিড দিতে পারলে ভালো হয়, যদিও আমরা ফলিক অ্যাসিড দেই। ফলিনিক অ্যাসিড দিতে পারলে ভালো হয়, বিকজ এটা তো জানেন সবাই যে এটা সরি ফলেট অ্যান্টাগনিস্ট হিসেবে কাজ করে। কিন্তু আমার কাছে মনে হয় যে যদি এটা 3 মাসের ট্রায়ালে দেখা যায় ভালো ইমপ্রুভমেন্ট হচ্ছে না, ডোজ না বাড়িয়ে আমাদের ডাক্তারদের জন্য বোধ হয় possibly this message will be much better that you go for JAK2 inhibitor like tofacitinib. Start with 5, then 10, 11 এর XR পাওয়া যায়, whatever maybe. আমি একটা প্রশ্ন আমি নজরুলের কাছে করে আমি বিদায় নিব। সেটা হচ্ছে, আমি অনেক প্রেসক্রিপশনে অ্যাপ্রিমেলাস দেখতে পাই। ওনারা কিভাবে বুঝেন যে এটা PD4 এর জন্য আমি দিলাম? তাহলে তো তাকে আরো অন্য কিছু চেক করতে হতো। তাহলে যারা এটা দেন তারা কি এটা গেস করে দেন, নাকি এটা কোনো এক্সারসাইজ করে বা এটা কোনো টেস্ট করে দেন? এই প্রশ্নটা প্রফেসর নজরুল অবশ্যই একজন বাংলাদেশের লিডিং রিউমাটোলজিস্ট, তার কাছে আমি একজন ইন্টার্নিস্ট হিসেবে আমিও ওই ছাত্রদের মতো প্রশ্নটা করে আমি আমার তরফ থেকে সবাইকে অসংখ্য ধন্যবাদ জানাচ্ছি। প্রেসিডেন্ট সহ, আজকে চেয়ার সহ সবাইকে, যারা দুজন বক্তৃতা দিয়েছেন, প্যানেলিস্ট, সবাইকে অসংখ্য ধন্যবাদ জানাচ্ছি যে এ ধরনের অনুষ্ঠান হলে we can learn, we can exercise, and we can improve ourselves again and again. Thank you very much.
Thank you, Professor Dr. Qazi Tariqul Islam, sir. Now this is the time for a speech of our president and conclusion. Before that, I like to request this program is sponsored by SKF Pharmaceuticals Limited. I like to request Mr. Mohit Nawaz, product manager. Please say a few words or vote of thanks for you being. Please, Mohit Nawaz.
ওনার ভোট অফ থ্যাঙ্কস এর আগে নজরুলকে একটা মিনিট দিলে ভালো হয়।
ও স্যার উত্তর দিবে। আচ্ছা
শাহিন, মানে স্যার তো মানে মুরব্বী মানুষ এবং সিনিয়র, বুঝতেই পারতেছো স্যারের সঙ্গে যদি কখনো একটু তোমরা কাজ করো কি ধরনের ক্লাসিক তখন বোঝা যায়, বুঝছো তো? যাই হোক, উনি আমাকে একটা কোয়েশ্চেন করেছে, আমি খুব ডিলাইটেড টু গিভ অ্যান্সার। তার আসলে বিষয়টা হলো আমাদের অবজারভেশন আর ডার্মাটোলজিস্টের অবজারভেশনের মধ্যে একটু পার্থক্য আছে। আমি স্যার অন্য ডিসিপ্লিনের কারো কথা বলছি না, এক্স্যাক্টলি আমরা যেটা দেখেছি আসলে আমাদের দেশে এই যে পেশেন্টগুলি আমরা ট্রিট করেছি, শাহিন আছে, শামীম আছে, স্যার থাকলে ভালো হতো, জলিল স্যারও কিছু জানেন। আসলে আমাদের এক্সপিরিয়েন্স উইথ এপ্রিমিলাস্ট ইজ নট গুড। এপ্রিমিলাস্ট সোরিয়াসিসের উপরে খুব ভালো কাজ করে, সোরিয়াসিসের ইমপ্রুভমেন্ট খুব ভালো করে, কিন্তু আমাদের আসলে আমাদের পপুলেশনে আমরা ভালো দেখি নাই। আমরা স্যার প্ল্যান করছি ভবিষ্যতে আমরা এটা দেখে যেভাবে সায়েন্টিফিক ভাবে বলা যায় এটার উত্তর দেব। তো তবে স্যার এপ্রিমিলাস্টের একটা সুবিধা এটা হলো যে ডোজ অ্যাডজাস্টমেন্টের বা পরে অ্যাডজাস্ট যদি হয়ে যায়, ডায়রিয়া যদি খুব ডিজাস্টার প্রবলেম না থাকে, তাহলে রেনাল অ্যাডজাস্টমেন্টের জন্য কিছু করতে হয় না। সো দ্যাট ইজ দি ওয়ান পার্ট। আর লিভারের ইভ্যালুয়েশনের জন্য মানে এটাও মানে তেমন কোনো সমস্যা না। বা আপনি যে কথাটা বলেছেন সেটার কিন্তু অন্য পার্সপেক্টিভ আছে, সেগুলি স্যার সেটা যদি আমরা মনে করি যে আমাদের ফসফোডাইএস্টারেজ 4 ইনহিবিটর, এগুলার আমাদের আরো অন্য কিছু ফাংশন আছে, সেই দিক দিয়ে খেয়াল করলে আসলে আমরা লাভবান হব না লুজার হব, এটা সময়ের বিষয়। আপনার এই ইন্টারেস্টটা স্যার এক সময়ে আমার মনে হয় কোন একটা ফোরামে বলেন, তাহলে আমি আরো গুছায় গেছে এই এটা রেজাল্ট রেডি করে আপনাকে জানাবো।
প্রফেসর নজরুল, আমি শুধু ছোট্ট একটু সাপ্লিমেন্ট করি যে ওই যে এপ্রিমিলাস কিন্তু এমনি ওয়ার্ল্ড ওয়াইড ডেটা হচ্ছে 40% ইফেক্টিভ, আর নসিয়া, ভমিটিং, ডায়রিয়া তো খুবই একটা বড় প্রবলেম, তো ওই জন্যই খুব জনপ্রিয় না, এবং একদম নিচের দিকে রিকমেন্ডেশনস কিন্তু নিচের দিকে, কোনো উপায় না থাকলে তখন দিতে হবে, এইরকমই রিকমেন্ডেশন। তারিক স্যার যেটা বলছেন ভেরি নাইস, যেটা আসলে আমরা প্রেফার করি।
মিনাজ, আমি দেখছি যে ডার্মাটোলজিস্টরা ফ্রিকোয়েন্টলি লেখেন, আমাদের কাছে তো কোর্স অ্যাকচুয়ালি প্রেসক্রিপশন তো মুভমেন্ট করে। So I have said, okay, thank you very much. Stop this. Carry on, Shaheen.
আর লেখাটা কি কমে গেছে কিনা? ডার্মাটোলজিস্টরা আগে যেভাবে লিখতেন এখন কি সেভাবে লিখেন কিনা স্যার?
এটা নিয়ে আর কথা বলার দরকার নেই।
আচ্ছা স্যার, থ্যাংক ইউ স্যার। মোহিত নওয়াজ, প্লিজ আপনি দু একটি কথা বলতে চাইলে বলেন।
Assalamu alaikum and a very good evening. Respected doctor, I'm Mohit Nawaz, product manager of SKF Pharmaceuticals. And it gives me immense pleasure to thank Bangladesh Rheumatology Society, Department of Rheumatology, BSMMU, in association with BD Physicians for organizing such a wonderful scientific session on this World Arthritis Day. It's really a big honor for me being present here with all legendary professors of Bangladesh. And today's discussion on management of psoriatic arthritis and the approach to a patient with joint pain was really informative and helpful for us. And I'm sure the audience will be highly benefited from this discussion. Being one of the leading pharmaceutical companies in Bangladesh, SKF Pharmaceuticals operates with a quality-driven mindset. Moreover, SKF's manufacturing plant is approved internationally by various stringent regulatory authorities such as UK MHRA, TG Australia, EU GMP, and the company is currently exporting medicines to many countries across 4 continents, including some highly regulated markets in Europe and Australia. The esomeprazole preparation of SKF, Isoral MAPS, is the knowledge partner of today's session. Isoral MAPS is the only German tech micropellet esomeprazole of Bangladesh. Due to the use of German tech, Isoral MAPS is faster acting with longer action and has dosing convenience, can be taken with or without food. On behalf of SKF Pharmaceuticals, I want to thank Bangladesh Rheumatology Society and Department of Rheumatology, BSMMU, along with BD Physicians for giving SKF to be a part of today's session. We hope that SKF will get the opportunity to be a part of your next scientific session as well. I thank you all for your participation. Thank you.
ধন্যবাদ ডক্টর, ধন্যবাদ মিস্টার মোহিত নেওয়াজ, এবং আমি ধন্যবাদ জানাচ্ছি ডক্টর এহসান। আমি এখানেই শেষ করব। এখন হচ্ছে আমাদের টাইম ফর আমাদের প্রফেসর এম এ জলিল চৌধুরী স্যার, আজকের অনুষ্ঠানের চেয়ারপারসন স্যার ওভারঅল সাজেশন এবং কনক্লুড করবেন স্যারের বক্তব্য দিয়ে। স্যার প্লিজ আপনার বক্তব্য।
Thank you, Dr. Abu Shaheen. I have to conclude very soon because very soon the rheumatology ward arthritis day will expire. Only 5 minutes, 3 or 4 minutes are remaining to expect the World Arthritis Day. However, I am feeling very much happy to be with you all, many legendary rheumatologists of the country, and including all many panelists who joined this CME. And I am happy to see that the Rheumatology Society has not forgotten their past president. So thank you for inviting me to chair the session. So everything has been talked. The topic chosen is very much appropriate, and the speakers are also well known to us. They are all reputed rheumatologists of the country, and their presentations are excellent, very rich in contents, and they could attract many of the participation. And all the panelists have also contributed very much. I should appreciate the presence of Professor President Professor Syed Atiqul Haq, Professor Qazi Islam, Professor Mujibur Rahman, Professor Tito Mia, and many others. But on the list, all the participants. But we are sorry that we couldn't answer many of the intelligent questions. The slogan is yes, this is the time to interfere. Actually, we should interfere the activity of the rheumatic disease in time. We have learned many things from their presentation. But one thing I'd like to share with one question. It is not related to rheumatology, but related to many subject. That is referral. Yes, this is very much important. Referral system. The country is not going for referral system. But আমরা যখন পড়াইছি বা পড়াই বা পরে যারা পড়াবে, এই জিনিসটা কিন্তু খুব গুরুত্বসহকারে আমরা যখন রেসিডেন্সি প্রোগ্রাম চালু করি, তখন এই ধরনের জিনিসগুলোকে আমরা বেশ গুরুত্ব সহকারে আনার চেষ্টা করছিলাম। আমি আশা করি সেগুলো চিন্তা করা হচ্ছে, এখন বেশি আরো চিন্তা করা হবে, এবং আমাদেরকে শিখাইতে হবে, এবং যারা ছাত্র তারাও শিখতে হবে when to refer, how to refer, whom to refer। এগুলো কিন্তু একটা বিরাট সাবজেক্ট। আমাদের রেসিডেন্সি প্রোগ্রামে কিন্তু একটা টপিক ছিল। আমরা কিন্তু আগেও জানতাম না, আমরা শিখেই নাই হাউ টু রেফার। আমরা লিখতাম স্যার ওটিপি রাখি, তো ওনারাও তো এটা হচ্ছে আমরা বেরিয়ে আসার চেষ্টা করছি। তো রেফার একটা জিনিস, এটা আমাদেরকে শিখাইতে হবে, এবং যারা ছাত্র তারাও শিখতে হবে। সুতরাং so I must thank all the participants, panelists, and organizers, beneficiaries, and not the least escape. Thank you all. I think I should conclude by 12. Thank you all.
Thank you, sir. Welcome, sir. Nazrul sir, thank you, sir, for excellent presentation, and also Shamin.
খুব সুন্দর বাজান এখন।
জি স্যার, খুব সুন্দর হচ্ছে।
এসকেপ লাইভ ক্লোজ করে দেন।
12টা মধ্যে ধরতে পারছে সবাইকে, এটা কম গুরুত্বপূর্ণ না। এটা ক্রেডিট আমাদের যে সবাইকে 12টা মধ্যে ধরতে পারছে।
তবে
সবাইকে থ্যাংক ইউ, ধন্যবাদ।
জি স্যার, শাহিন ইচ্ছা করলে 35টা বই সবাইকে দিয়ে দিতে পারতো স্যার, মানে
সেটা
না পুরো ভাবছে
আরোগুলা কোশ্চেন, ছেলেমেয়েরা এতগুলা কোশ্চেন করলে স্যারের বইটা
দেবে না বললেন তো, দেবে না বললেন তো
না স্যার। কোশ্চেন তো স্যার আপনারা তো কোশ্চেন শুধু এখানে দেখছেন স্যার। আমাদের তো স্যার আমি একটু বলি স্যার,
বলেন স্যার।
স্যার আমাদের তো লাইভে তো আরো কয়েক হাজার ভিউয়ার ছিল। এটা তো স্যার শুধু আপনারা জুম দেখতেছেন, আর ওইখানেও স্যার অনেক কোশ্চেন ছিল স্যার। আবার লাইভে ভিউ অন্তত 2 থেকে 3 হাজার তো লাইভ ভিউ আছে। ওইটা তো স্যার আপনারা দেখেন নাই স্যার, ওই কোশ্চেন গুলো তো বাদ দিলাম স্যার।
এগুলা একটু লিস্ট করে রেখে একসময় কোশ্চেন অ্যানসার সেশন করা উচিত।
2-3 হাজার বই তো দিতে হবে স্যার,
লিখিত করে অ্যানসার
না। নেক্সট সেশনে স্যারের বইটা আমরা স্যার ফার্স্ট 100 জনকে দিব স্যার, মানে নেক্সট আমরা যেটা প্রোগ্রাম করব স্যার।
তবে স্যার আমরা